If you look at the heart in your table, actually, if you were doing heart surgery, the heart will be like this. The head will be on this side, and the feet will be on this side. If you see this line here, that's a blood vessel. It's called the left anterior descending coronary artery. And that separates the right ventricle from the left ventricle. If you pinch the right ventricle, you see how it's kind of soft and thin. If you pinch the left ventricle, it's kind of stiff and thick. So basically, the right ventricle is very good at pumping volume because it kind of distends a little bit and works like that into a low resistance territory, which is the pulmonary vasculature. The left ventricle, being thick and strong, is good at pumping pressure, but not very good at pumping volume. So when you have left ventricular failure, you can't really pump all the volume that you need to, and that's why you start getting backup volume into the lungs, and then you develop pulmonary edema. Whether on the right side, it usually pumps pretty well, but also if you have right side failure, you get pedal edema, hepatomegaly, ascites, and so on. You can also get renal failure from poor venous drainage from the kidneys. If we look in here, on the right side, this is the right atrium. That's to the right of the left anterior descending coronary. That's the right atrium. And this little funny looking thing here is the right atrial appendage. This is the one when they put a pacemaker, they kind of hook it into for the atrial lead, and then the ventricular lead goes into the apex of the right ventricle. On the left side, the left atrial appendage is this one here. And you can see it partially going posteriorly on the heart. The left atrial appendage, like a little auricle that comes off the left atrium. Now, when you have atrial fibrillation, the left atrial appendage is the one that develops most of the clots and the ones that can cause clot embolism with consequent strokes or renal infarcts or bowel infarcts or leg ischemia. So the left atrial appendage is an important thing, and the left atrium is the posterior most structure of the heart, and it's behind here, behind the left ventricle. The reason for that is vascular tube in the embryo life, it falls upon itself, and the ones on the back are the atria and the ones on the front are the ventricles. So the left atrium is the posterior most structure of the heart. If you look at the left atrial appendage and lift it up a little bit, you're going to see a vessel here. That is the circumflex coronary artery. It goes very close to the atrial appendage. So sometimes when you ligate the appendage or you cut it or something, you have to be careful not to damage the circumflex coronary artery. The other thing here on the front is the pulmonary artery, which is here, and you can see the right ventricle pumping blood into the pulmonary artery. And then behind the pulmonary artery is the aorta and the great vessels. So the pulmonary artery is anterior, and the left ventricle, which is posterior to the right ventricle, the aorta comes from behind the pulmonary artery, and there goes around and in front of the pulmonary artery. If you turn it the other way around, you will see kind of like a soft tissue here in the back. That is the coronary sinus. The coronary sinus is the main vein of the heart. And we're used to give cardioplegia through the coronary sinus, and that's what's called retrograde cardioplegia during heart surgery. If you look at the right atrial appendage, you're going to see the right coronary artery will come here on the groove between the atrium and the right ventricle, and then it goes in the back of the heart on the inferior wall. That is the posterior descending coronary artery. So the posterior descending coronary artery, because the heart normally is in this position, it'll be in the back. That's why it's called posterior. Contrary to the anterior descending, which is branch of the left, the posterior descending is branch of the right coronary artery. And that will be down here. Again, between the left and the right ventricle. If you grab the pulmonary artery, we're going to cut it. And we're going to separate it from the aorta, which is behind it. So if you look inside here, down at the bottom will be the pulmonary valve, right at the exit. And then the pulmonary artery, the main trunk, splits into two branches. One goes to the left, and one goes to the right. So now behind the pulmonary artery here is the aorta. You see how the pulmonary artery is thin? We're always very fearful in surgery about injury to the pulmonary artery because it's very thin and very difficult to repair. Contrary to the aorta, which is usually thick, and even though it has high pressure, it makes it easier to repair for the most part. Let's turn the heart down like this, and we're going to find the superior vena cava here that goes all the way down into the inferior vena cava. You see, they connect. That's the reason that sometimes when you different surgeries, you can go from the groin through the inferior vena cava all the way up to the superior cava when you need to do like perfusion. Instead of bicaval cannulation, you can just do that and perfuse through there. Also, you can go through the superior vena cava down into the inferior vena cava to put a inferior vena cava filter or other procedures in the inferior vena cava. So we're going to cut this channel. So when you cut between the superior vena cava and the inferior vena cava, all that trajectory, basically you are opening the right atrium, which is this cavity here. That's where all the blood from the body comes back to. And from there, you can see several things. Number one, see these muscle fibers here? These are called trabecula. And those are from the right atrial appendage. That's what allows pacemakers to stick to, because they get stuck in there and then they work like that. Down below is the coronary sinus. The coronary sinus goes around the back of the heart, like that. Over here is where you would have a patent foramen valve if this was open. This is the septum primum and septum secundum, and they fuse right after birth. And if they stay open, then you have the most common atrial septal defect, which is an ostium secundum atrial septal defect. You can also have, or ASD, you can also have one up higher here, which is a little more difficult to repair, but also part of the development of the right side of the heart. If you look deep inside there, you're going to see the tricuspid valve. And to have a better look at that, what I'm going to do is I'm going to cut to the side of the posterior descending coronary artery. Like that. All the way to the apex. And then you can see the leaflets of the tricuspid valve. Here, this is 1, 2, and 3. That's why it's called tricuspid. And you can see how the leaflets is a thin tissue, and it's got this little chordae, and then they have the papillary muscles here. Can you all see that? Okay, now we're going to transect the aorta. If you look at the heart like that, there is a tract here that connects the right side of the body to the left side of the body. We use that sometimes to connect the right mammary artery to the circumflex coronary so that it will reach. But basically, this big blood vessel here is called the aorta. So we're going to cut it here where we can see it. We had already cut the pulmonary artery, which is in front of the aorta. And now we have cut the aorta itself. If you look inside the aorta, you're going to see the aortic valve. The aortic valve has 3 cusps. We may need to cut the aorta a little shorter so that you can see it better, but let me. It's inside here. There are 3 very thin leaflets also. And then the next thing we're going to open is the left atrium. And to do that, remember the left atrium is the posterior-most structure of the heart. So if this is the front, it's going to be in the back here. And because they already halfway cut this, some of that may not be as easy to identify. But once you do that, so this heart of mine had a pretty tiny left atrium. But we're going to do the same thing. Let's open the heart now, like I explained to some of you. We're going to go along the other side of the posterior descending artery. Dip into the left ventricle. Can you all see that? Okay, so here you're going to see the mitral valve. There is 2 leaflets. One is anterior and one is posterior. This is the posterior. Remember, the heart is like that. And then you're going to see two papillary muscles. One is attached to the posterior lateral wall, and the other one is anterior medial wall. So those are the two papillary muscles. And then the mitral valve leaflets with chordae tendineae. So the chordae come from here, mostly to one side, but also to the other. So the papillary muscles contract and push the leaflet down, and the annulus contracts a little bit, and that's what makes the valve competent. So that's why either when you have a heart attack and the papillary muscle doesn't work, then you get mitral valve insufficiency through there. Or if the heart dilates, then everything dilates and the leaflets don't go out. That's another reason to have mitral regurgitation. Now, if you see here on the bottom, you're going to see the left atrial appendage. This one has a big one, you know, some of yours may be a little smaller right here. That's the left atrial appendage. So when they put a Watchman, you can see that they put it inside there to occlude it. When we put a mitral, an Atria clip in the operating room, it goes right here, kind of like that. And that obliterates the appendage and won't let it develop any clots. Now you can see how behind the anterior leaflets goes the aorta. Okay? So when the mitral valve closes, as the heart contracts, it also opens the tract for the aorta to empty. This part here is the left ventricular outflow tract down there. And it comes up through the aortic valve into the aorta. Yes? And we're going to open this here now. So now you can see the mitral valve, which when it closes, opens the outflow tract. And then you're going to see the aorta and the aortic valve. Now the aortic valve is open, so you can see 1, 2, and 3 cusps. And then here, you're going to see the ostia of the coronary arteries, 1 and 2. Let's tilt the heart back to the front here, where we have the left anterior descending. And we're going to, when they are dead and no circulation, it's hard to differentiate between artery and vein, but I think this is the artery, left anterior descending. All these little branches here are called diagonal branches. And depending on where the blockage is, you go distal to the blockage. And then you open the artery. And then you connect. See that? That's the artery there. And then you sew either the mammary or you sew a piece of vein here and then in the aorta, so that the blood will go from the aorta to the artery beyond the area of the blockage, bypassing the blockage. That's why it's called a coronary bypass. Okay. I guess last but not least, we'll talk about the aorta here. Whatever we had here left. You can see this is the ascending aorta. We kind of left attached to the heart and a little bit up here. Then you see the aortic arch, and it's got normally for humans 3 branches. In pigs, I think it has only 2 that give Each one of these give branches to the brain, carotid arteries, and to the arms or hind legs. So if we open it here, you can see 1 and 2, and then it goes down into the descending thoracic aorta, and then eventually into the abdomen, where they give branches to, the celiac axis, superior mesenteric artery, 2 renal arteries, and inferior mesenteric. Okay, thank you all for coming.